Good afternoon, everybody. My name is Lori Gert. I am one of the Quality and Patient Safety Advisors here with the Indiana Hospital Association. Thank you so much for joining us today. We have a jam-packed hour with our friends from the Richard L. Rodebush Veterans Affairs. We are recording this. It will be distributed. The recording will be distributed after the presentation. And I will be manning the chat. So if you have any questions, you can feel free to chat those in. I will be looking at that and helping our presenters manage the Q&A. And I would like to hand the mic over to Lori DeYoung. She's going to be our facilitator and our host, and she will take care of introducing her team for us. So Lori, the mic is yours.
Thank you very much, Lori. It's a pleasure to be here. Good afternoon. I'm Dr. Lori DeYoung. I am one of two community engagement and partnership coordinators at the Indianapolis VA Medical Center. Before we get started with the webinar, I'd like to introduce to you those on my team who are joining me today. And if they are on, if they could just turn on their cameras if you are able to. I know Mr. Turney is by phone, but if you could turn it on so everybody can see you. I want to introduce you to our team because they're going to join me today in being able to share information on the Compact Act and to be able to answer your questions on how we together can support those who served our country when they are experiencing an acute suicidal crisis. So joining me today is first Vicki Williams, Chief of Community Care, Craig Lewis, Suicide Prevention Coordinator, Stephanie Duran, Caregiver Support Program Manager, L. Michelle Brown, Medical Foster Home Senior Service Coordinator, and LaWanda Gurton, Community Engagement and Partnership Coordinator, who has also graciously agreed to manage our slide deck for me today. We're also fortunate to have with us Ashley Maynard, the Program Manager of the Indianapolis VA Medical Center Suicide Prevention Team, Mary Stevens, Integrity and Compliance Officer, Donna Raven, Veteran Experience Officer, Angela Judy, Chief of Community Care at the Northern Indiana VA Medical Center, Ms. Charla Borgert, Acting Chief of Community Care at the Dayton VA Medical Center, and Sylvia Maxner, Deputy Director of the Integrated Primary Prevention Program with the Indiana National Guard. Last but not least, I would like to introduce you to Mr. Mark Turney, who is our Chief of Public Affairs, who's with us via phone today and wanted to start the presentation with a few words. So Mr. Turney, the floor is yours.
Thank you, Lori. And I don't want to take a lot of people's time today. I just want to thank the IHA for graciously hosting this very important topic and allowing us the opportunity to present. And I'd like to give a special thank you to Dr. DeYoung. Without her, this whole thing would not have been possible. So on behalf of the director of the Richard L. Rodebush VA Medical Center, myself and my team, thank you all for coming and attending today's meeting. And Dr. DeYoung, it's all yours.
Okay, thank you, sir. And I would like to also thank Ms. Madeline Wilson, Lori Gert, and Casey Hutchins, who without them and the IHA would not have been, we have not been able to do that, this webinar. So LaWanda, if you could please advance to the next slide, please. The Suicide Prevention Program at the Department of Veteran Affairs has been in place since 2007, and the prevention of veteran suicide is our top clinical priority for each of the 170 VA medical facilities across the United States. Although you may hear an array of different statistics about the number of veterans who die by suicide, let's be honest, one is too many. But with that being said, here in Indiana in 2020, 150 Hoosier veterans died by suicide. And although there are 8 VA medical centers that cover the state of Indiana providing care to those who served our country, none of us can reach every veteran experiencing an acute suicidal crisis without community partners like you, the Indiana Hospital Association, and each of you from your hospitals that are present today. Next slide, please. So the Veterans Comprehensive Prevention, Access to Care, and Treatment Act, otherwise known as the Compact Act of 2020, was implemented on January 17th of 2023. This act will allow the VA to provide, pay for, and reimburse emergent treatment for eligible veterans experiencing an acute suicidal crisis. So those eligible veterans in that acute suicidal crisis are going to have access to no-cost care for items such as initial ambulance transportation, emergency care, prescriptions, up to 30 days of inpatient treatment, or up to 90 days of outpatient treatment, either in the community, at your hospitals, or at a VA facility, in order to address that acute suicidal crisis. This act expands care for more than 9 million eligible veterans who are not currently enrolled in the Veterans Health Care System. Next slide, please. So the first step to this process of getting our veterans to care when they are experiencing an acute suicidal crisis, if they do not self-present at your hospital or in our hospital, is going to be with those trained crisis responders, law enforcement, fire protection, emergency medical services, the Veterans Crisis Line. So it is key that we provide tools to those trained crisis responders with information around how to get that individual who is experiencing an acute suicidal crisis to the care they need when they need it. And out of that, that desire to really support those trained crisis responders, we came up with here at Indianapolis VA a pocket card that we are going to be providing not only to all law enforcement within our catchment, but also to community hospitals. And I will be sending the link to that to Lori and Casey and to Madeline to get out to all of you after the presentation. Next slide. So this is a copy of what that pocket card looks like. This was done in collaboration between CEPCs, myself and LaWanda, the PAO's office, Mark and his staff, the suicide prevention team, and our internal review team for the Compact Act, including Ms. Williams, Ms. Stevens, Ms. Raven, and all the others that are present with us today. And so our goal with this pocket card is to make sure it gets in the hands of all those trained crisis responders who may be meeting veterans in the midst of that emergency crisis. And so what the card is doing is basically saying, if you are encountering a veteran in an acute suicidal crisis, just take them to the nearest emergency room for care. And if you are taking them to a community hospital, share this card with those hospital staff in the emergency rooms that has instructions that maybe they're not familiar with in order to access this treatment under the Compact Act. Next slide. So on the back side of this pocket card that we're going to be providing to you and to trained crisis responders, basically gives you a step-by-step process of some of the initial things that need to occur when that veteran in an acute suicidal crisis is presenting at your facility. And it's very blurry on this slide, and I apologize. I don't know why I wasn't able to get it to come out as clearly as it does when I send it out in an email, but you will all get copies of this to use and to distribute within your facilities. But the first step is when that veteran presents at your hospital, please contact the National Emergency Reporting Center. And it's got a number 844-724-7842, or visit, and there's a website that you can go to that you can then alert our VA system that you have a veteran in your emergency room care. The next step is if you are needing to transfer a veteran to our facility for care, to contact our bed management and interfacility transfer coordinator. And again, there's a number on this card that you'll get that's a little blurry on this slide. And we have Miss Vicki Williams with Community Care who's going to be able to talk a little bit more about that whole process. The third step that you would need to do is to fax your records as soon as possible within 72 hours to our bed management and interfacility transfer coordinator. And there's a fax number on there. And it's really important that you indicate on those records that that veteran presented to your facility and is receiving treatment for an acute suicidal crisis. And then the last step that Mr. Lewis is going to talk about after me here is you can always contact our suicide prevention team, and they man this email and receive information by this phone at all hours during the week. So next slide. So I'm going to introduce Mr. Craig Lewis, Suicide Prevention Coordinator, and the slides are now yours, sir.
Thank you, Lori. Yeah, so our first slide here, this just shows our team and how our team is structured. So our team is comprised of, the previous slide kind of showed our team is comprised of, we have 6 suicide prevention coordinators. And the role of the suicide prevention coordinator is kind of unique. Our program is a program that other healthcare systems don't really have. So just to kind of give you a little bit of an overview of what that looks like. If our team is informed of if a veteran has attempted suicide or engaged in preparatory behavior within a certain time frame, what we do is we actually put a notification on the veteran's medical chart. And then our team on a weekly basis will actually follow that veteran. We will, at a minimum, do a chart review. We also will outreach to them by phone, and we're essentially just another layer within our system to just check and make sure that they're getting the care that they need, that they are not falling through the cracks, and also that they're safe and they're doing okay. We also get referrals from the Veterans Crisis Line. So we'll have referrals that people will call 988, just the national crisis line number that you all know. And there's an option to press 1 when you call if you're a veteran, and it will transfer them to one of 3 national call centers. And then what'll happen is the next business day after a veteran calls the Veterans Crisis Line, we will get, not in every case, but in most cases, we will get a referral to our team that basically is pretty much a synopsis of that call. And it'll have, if there's any follow-up locally that needs to happen. So if the veteran is interested in getting linked with outpatient mental health, or if they have a concern or an issue within the care that they're receiving, or they need to be linked with resources such as housing or something else in the community, they let us know about those. And then our team, the next business day, will outreach to that veteran and try and link them specifically with those services. And another thing that we do is we essentially train our team. The SPCs are kind of in charge of all of the training for staff at our facility as far as how we screen and assess for suicide. And so we do trainings not only locally within our hospital, we also provide trainings within the community as well. So there's a training called VA Save that we do that is pretty similar to QPR, if anyone is familiar with QPR on this call. We provide that within the community for free for anyone who is interested. And really what that training, the purpose of that training is just to teach people to have the skills that they need so that they can help keep a veteran alive until they can actually get them to mental health professionals to be able to address whatever crisis they have going on at that time. One other thing that we do as SPCs, anytime we are alerted, our community care team is alerted kind of through that process that Lori just described. If a veteran does present to an outside hospital, and if people from the various hospitals that are represented here let us know that, our community care team is informed of that. And then what we do after our community care team informs us, our team will actually reach out to those hospitals in the community. And we do that really for a couple of reasons, but the main one is we want to just make sure that there's coordination of care between our facility and your facilities. The last thing we would want to have happen is a veteran present to a hospital in the community while they're in crisis. And then if they are eligible for VA healthcare and they have an interest in following up with VA healthcare, last thing we want is for them to go from an inpatient setting to not having any clinical follow-up following that inpatient admission, or even if they just present to your ER. Either way, we want to know, we want to be able to assist them with being linked with whatever care they actually need. And then the other part of the slide here is the community engagement and partnership coordinators. That would be Lori and Lawanda, and they do a lot of things. As Mark Turney mentioned, the reason for this actual call is because of all the work that Lori did to kind of help set this up. And part of also what they do is they create and establish new community coalitions to support our suicide prevention efforts within the community. And they also work with things such as the Governor's Challenge, which is going on right now, which is a partnership between SAMHSA and the VA that they're doing throughout various states throughout the country to try and basically address the concern of the high rates of suicides for veterans within our communities. And you can go to the next slide. So when our team is actually alerted to a non-VA outside hospital case, those are potential Compact Act cases. And so here's kind of how things go. We're usually alerted when a veteran presents to a non-VA outside hospital. And if the chief complaint is suicidal in nature, then we are informed of that a couple different ways. We're informed that there's an emergency notification email that we receive. And then we could also be alerted within our medical chart by the community care team, or we also at times are alerted via the Veterans Crisis Line, those referrals that I mentioned a minute ago. After receiving that alert, we do a couple different things. We outreach to the non-VA outside hospital, we outreach to you guys, and we do that, as I mentioned, for the purpose of coordinating follow-up mental health treatment for that veteran, or honestly, any other treatment that they need for follow-up purposes. And we do this primarily because research indicates that after a veteran presents in a suicidal crisis, that having a follow-up mental health appointments reduce the likelihood of that veteran dying by suicide. And one of the primary barriers that we have is a lack of reliable contacts at many of your facilities. That can make it pretty difficult for us to coordinate care. And one of our other concerns also is that it could also make it a little bit more complicated for your staff with their discharge planning. One of the things that we like to do is provide any information and answer any questions they would have about VA care so that your staff can have a better idea of who to contact, how to actually schedule appointments, and do all of those things, which I know can be tricky when you're trying to navigate a large healthcare system. And just another example that I had just recently, just this past week, as another example would be, we have at times we will call after we have been informed actually by your facilities that a veteran is admitted to your facilities. And so we know that a veteran is actually admitted to your facility, and then the staff will actually kind of put up the HIPAA wall and say, hey, we can't tell you anything. And we already know that the veteran is actually admitted. And we're not even actually asking for them to disclose any information. In most cases, we're just wanting to try and provide them information that could be helpful, that could assist them with discharge planning, just for really coordinating care. And so any assistance that you can provide us in trying to have reliable contacts would be much appreciated. And I think next slide, I think I'm handing this off to, I believe, Vicki.
Let me interrupt just a second. Craig, I'm going to give you the opportunity to answer a question in the chat now, or if you want to defer it to the end, we'll move it to the end. But it does tie into the communication with the VA and the outside hospitals. And the question is this: how does obtaining consents and releases of information from those veterans that show up in our ERs fit into that process of then contacting us? Can you shed any light on that, or do you want to wait until the end?
So obtaining those consents and releases. So I think for Compact Act purposes, you can let us know that a veteran is there. And really the idea is that it can cover the cost of that care for the veteran. And having those consents is always helpful. We would always prefer that if the veteran is open to that. I've had instances where it's actually been helpful, and it's been beneficial for me to speak directly to the veteran. So, because there can be, we can have this instance where the staff at a non-VA hospital really wants to answer questions clearly about stuff relating to benefits or different things that the veteran might have, but just understandably don't have the knowledge base to do so. And we can help out with all of those things too. I think as a general practice, if you can have a release, that's incredibly helpful. But in terms of us trying to just coordinate and just we can provide you guys information. We're willing to provide you guys information if it would help, no matter what that would be, as long as we're not breaking HIPAA, to be able to support the care of the veteran and the ongoing follow-up treatment that needs to happen after an admission.
Okay, thank you. Thank you, Mr. Lewis. Ms. Vicky, would you like to take over? Lawanda, please advance the slide.
Sure. This is our team here at the Indianapolis VA Center. So you can see we have myself as the section chief, Lori Kinder as the business manager, Cassandra Lynn is our nurse manager. We do have a central phone number. So anytime you have any kind of questions for community care, you just dial that central phone number and our phone team will direct you to the right team or person. We also have a vendor reimbursement or a vendor relations team to assist anytime you have billing problems, and you can send them an email at the address shown below. All right, please advance. So this slide contains some important facts regarding emergency care, and it's really for all veterans, not just those who present for acute suicidal diagnosis. So in 2020, the VA established a national ER reporting call center, and that the purpose of that center was to simplify reporting and also to expedite payment decisions. And I'm sure that you are happy to know that that center has been effective in doing that. But for that system to work very efficiently, we do need for you to follow the instructions that are listed here on the slide. So that the first thing is so very important. Please call and report an emergency presentation within 72 hours. It is very important. It's by the minute, and that will ensure an expedited review of the presentation diagnosis. If the veteran is to be transferred to the Indianapolis VA, there is a phone number directly to our interfacility transfer nurses. They will facilitate making that transfer happen. Now, something to note is if this is an acute suicidal event, there is no mandated transfer requirement. So the veteran may remain in your care. They do not have to transfer to the VA. But if a veteran presents for a medical surgical diagnosis, then once they are stable, a conversation should be held to try to determine whether or not it's appropriate to transfer the veteran to the Indianapolis VA or to whatever the closest VA is. The other thing that will help to ensure prompt payment is to send those records as quickly as possible. We do have a team who works on making those records requests, but if you are already aware of the need and how this helps us, especially with our suicide presentations, to get the appropriate care lined up secondary to their inpatient admission, getting those records to us promptly is extremely important. So other important notes on this slide is that an authorization for an emergency care is only from the time that they present to the time they're discharged. It does cover an admission if that is required emergently, but the authorization is only valid within that time period. So if additional services are needed, if a follow-up is required, there does need to have a pre-authorization in place from the VA. So that means that communication is very important in those records so we know what the plan of care is. Please do not schedule follow-up visits or make transfer without contacting the VA first to get those things in place. There is a link here on the bottom of the page that takes you directly to the VA Community Care Optum website. You can access a document called a request for services, fill that out and fax it to the phone number there listed, and our nurses in community care will help facilitate getting anything arranged as far as follow-up care after the discharge. So very important, make the phone call within the 72 hours, get us those records, and make sure you have pre-authorization for any kind of follow-up care. And that's what I have to speak on. Thank you very much.
Thank you. Next slide, please. So what we wanted to do today was to give you just kind of a brief overview, one, to meet the team involved in the Compact Act and to know some of the people internally at our facility. We know that our system is very large, and sometimes without actually seeing people or knowing names, it can be rather daunting. I mean, our veterans face that all the time, and we really are wanting to break down some of those walls and give you access to those of us on the inside that could maybe help navigate that veteran, their family, their caregivers, and your staff in this and other relationship facility kind of activities that we need to, stay on top of. So in addition to this webinar, we're going to also offer some weekly virtual office hours next week. They're going to happen on Monday, Tuesday, Wednesday, and Friday from 3 to 4. I'm going to send that link. And it's if you want to pop in and you want to ask a question, or let's just say you're a hospital in Lake County, that's not within the Indianapolis VA's catchment, but I can connect you to staff at the Jesse Brown VA. Likewise, I was fortunate enough to be able to have Ms. Judy and Ms. Borgert available from Dayton and Northern. That is our goal in this follow-up virtual office hours, is to continue to answer your questions, be an ongoing source of support. Some of the other things that I have done with about 4 or 5 hospital settings thus far is that I've met with them individually in a Teams meeting and kind of walked them through and answered some of their questions, just so that we can make sure we have good communication and you don't feel like you're out there trying to navigate this without our support. So again, I'll be sending this link out to IHA and they can send off to all of you. Feel free. Many of us have put our contact information in the chat. We are more than welcome to answer your questions. And if we don't know the answers, we will find out and get you triaged to the right person who does know. It looks like there's another question in the chat. And this is, I'm going to open this up to anybody on the team. It says, does the VA consider an acute suicidal crisis as encompassing suicidal ideation and or suicidal attempt and or preparatory behavior? So Vicki, Craig, either of you, or Mary, any of you would like to jump on and answer that question? Craig, I see you on. Are you able to kind of answer that?
For Lori Gert, it's a tricky question, right? I understand where you're asking that. I think acute suicidal crisis is going to be defined by the clinician in the actual context that they're in, right? So I think probably pretty clearly if someone presents with a suicide attempt, or if they have engaged in preparatory behavior, especially if it's with an actual, there's actually a method in mind. So I'm thinking preparatory behavior with a rope or with a firearm, or, there's some progression in that behavior that could lead it to actually being an attempt. I'm differentiating that in some ways between writing just a note, but not having an identified method, and some of the other things that technically are a behavior, but aren't with an actual method. I would say those things are pretty safely probably an acute suicidal crisis. Now, someone just comes in with just thoughts of suicide, probably not. I think it would really depend on, that actual clinician and how they want to define an acute suicidal crisis, because I don't think there is necessarily one super clear black and white term on that. And last thing I will say about this is that one of the VA central office staff that kind of helped that be the actual criteria for the Compact Act, I had a conversation with that gentleman, and he said they intentionally kind of left it to be somewhat vague. So it could be something that could be determined by the actual clinician that sees the individual. So he said that they thought about actually having it being admitted to a facility, or, there's different things you could have done instead, but they left it more broad and they left it more vague. So it is at the clinical discretion of the provider who's assessing that individual during that clinical encounter.
Thanks,
you.
Craig. I hear what you're saying. It's Lori Gert, by the way, with the Indiana Hospital Association. And what I'm thinking about as I ask that question is knowing that some of our members on this call use the Columbia Suicide Severity Rating Scale, right? So that is a great tool for those clinicians to use, but I didn't know if the VA used that same tool or same language. So if we said, hey, this person's a 6, we know that's probably an acute suicidal crisis, right?
Yeah, so we probably use it a little bit differently than you guys do. It's either a positive or a negative screen with us, right? So like the Columbia Suicide Severity Rating Scale that we use is our first level suicide screen that we use. And we use the one that's 8 questions. And for us, if the answers to questions 3, 5, or 8 are yes, then it's a positive screen. And so for us, we basically from that, if that's positive, we have a more thorough screener that is done by an LIP because our CSSRS can be completed by essentially almost anybody when they present initially. But then an LIP is going to complete what we call the comprehensive suicide risk evaluation. They're actually in that assessing for the acute and chronic level of risk for self-directed violence.
Gotcha.
Right. And so for us, if it's a positive Columbia, we would not say they're necessarily in an acute suicidal crisis. It would be based on the assessment done by the LIP in the comprehensive suicide risk evaluation, which could very well be different than what you all do, but that's what we do.
Right. Okay. That helps though. If those folks here that you're speaking to are members, are saying, oh, well, we do have the Columbia as a screener, then they get a better idea of what you may be talking about in regards to acute suicidal crisis. So thank you for that.
Yes, thank you. Thank you, Craig. And, so 2 main key takeaways that we want to leave you with is that it's really important when a person is presenting to, 1, get that notification in and records and get that communication going with us within 72 hours. And then also ensure that your LIP, your treating physician, clinician, is denoting that the presentation and treatment is a result of the acute suicidal crisis. So next slide. I just wanted to provide the 4 main names who prepared this half of the presentation. Mr. Turney, myself, Ms. Williams, and Mr. Lewis. We were the ones who really tried to put this together in a thoughtful way that would give you some information that would be useful to take back to your hospitals. Again, we are going to be offering ongoing support through virtual office hours. You are also welcome to reach out to any of us and we will follow up with information. I did see in the chat that Ms. Stevens, yes, I will get you linked to the people you need linked to in Marion. So just email me or reach out to me after this and I will make those connections for you. Also, I'm wondering if did somebody put another question in the chat? I want to make sure I did not miss anything. I think we're good. You will note we aren't done with the presentation. We're done with the Compact Act part of the presentation. So we're going to move into the next part of our presentation. So I have put in the link in the chat a link to a survey. We really want your feedback. So please take the time to let us know how could we have made this better? Did we answer your questions? Are there additional questions that you have? Ms. Lindsay, you can add your, are you talking the survey? Can you come off the mic or put it in the chat? Are you talking on the survey? You don't have to identify yourself on the survey. It can be completely anonymous, but if you want us to reach out to you with additional technical support, we are going to need a way to get a hold of you. Yes, we will share the slide deck. After the presentation, I will request that IHA send that out to you. We're going to work on the formatting of it so that it's able to be opened up by you. Okay, I would like to thank the presenters for the first part of this presentation, and I would like to move on to the next slide, please. So this next part is got to do with what Craig kind of talked a little bit about the role of the community engagement and partnership coordinators and how we work within communities, not just to address the acute suicidal crisis, which has been the focus of the Compact Act and how we move forward on that, but how to work with individual communities and organizations and entities to prevent the risk of suicide, to reduce the risk of suicide for those who serve. So this part of the presentation is on community-based efforts to reduce the risk of suicide for our service members, veterans, and their families. Next slide. So if I could just have, I don't know if Sylvia, you're on camera. I don't see you on. I see Lawanda. The three people who are going to be presenting in this part is going to be Ms. Lawanda Gerton, my colleague as a community engagement and partnership coordinator with Indianapolis VA, and Ms. Sylvia Maxner, the deputy director of the Integrated Primary Prevention Program at the Indiana National Guard. Next slide. Lawanda?
Yes, thank you so much, Dr. Lori and Craig and all of those that have had an opportunity to speak prior to this time. I'm going to give a little bit more information regarding the community engagement partnership portion. Craig alluded to some of this, but I just kind of want to give a more in-depth analogy and more information about our role as community engagement partnership coordinators. And of course, now that the Indiana Hospital Association is a partner with us at the VA in these efforts, Dr. Lori and I and my other colleagues too as well, we go across the state of Indiana and we build coalitions. We help individuals that are interested in the prevention of suicide amongst those veterans and those that are connected, military connected. So we help build those coalitions, or oftentimes we will connect ourselves to existing organizations, such as the hospitals. We know, matter of fact, that this wonderful partnership with the hospitals across this state, all veterans do not come to the VA. And so it is key that we do everything that we can in tandem with each other to help and aid in the prevention of suicide. And so you can see here, there's an entire model, a health approach, a model that I'm going to give you a little bit more information about, along also with my colleagues. This community-based intervention for suicide prevention is on every level. It's on the national level, state, community level, and then of course we work with those community partners such as yourselves. And so all together with the Governor's Challenge, we have to make sure that we include the veterans and those that are military connected in this intervention as well. They are key partners with us. And then the community engagement and partnership for suicide prevention expansion. One of the key things as it relates to the Governor's Challenges, there are some priority areas that we actually focus on. I want to give you those three priority areas. You have identifying service members, veterans, and their families, and screening for suicide risk. In addition to that, we have promoting connectedness and improved care transition, and then increasing the lethal means safety and safety planning. These are the three top priority areas that the VA, SAMHSA, and then also in the Governor's Challenge. How wonderful is that it all lines up together, that these priorities for each of those organizations line up perfectly. And then with the hospital's assistance, we have a community partner that you're a glove. You're like a glove that fits perfectly as it relates to this. So we're going to focus on two of these today, primarily, and we have our subject matter expert here, Sylvia Maxner, and she is going to talk about the first priority, identifying those service members, veterans, and their families. And then Dr. Lori will come after her and discuss promoting the connectedness. So Sylvia, the floor is yours.
Thanks so much. So good afternoon, everybody. Just like Lori said, and Lawanda, my name is Sylvia Maxner. I'm the Deputy Director for the Integrated Primary Prevention Workforce out of the Indiana National Guard. This is a pretty new position, but suicide prevention is one of the major pillars of our work. And I'm very lucky to be able to work with the partners that I do, especially those of the VA and hopefully the ones here with IHA. So today, what I'm going to be talking to you guys about is our Ask the Question initiative. The goal here with Ask the Question is to both identify and then also better understand the military connected population. So let's just get straight to it. So next slide. So I said, what is Ask the Question? So the question we are asking all community partners to ask is, have you or a direct family member ever served in the military? If you notice, the question is not, are you a veteran? And the reason for that is we're wanting to capture the whole breadth of the military connected population. I think it's the next slide if you want to go to that, Londa. Oh, no, not this one. But I'm going to go through who we're talking about in terms of the military connected population so you can get a good understanding of why we're asking you to ask it the way that we are. But to get to the heart of it, I have up here on the slide an example of some of the good things that can happen when someone is asking the question. But I'd like to take a moment to give you a personal story about my dad. So I'm a military brat. My dad was career Air Force, but he did retire when I was in high school. Recently, he started to get pretty severe migraines, and he had a civilian non-VA physician who was helping him with those migraines. They tried a bunch of different things, a lot of pills, and it wasn't until the fourth appointment that they actually asked about his previous work experience. And that's where the military came up. That's where the discussions about the Air Force came up. And that connection between Air Force, airplanes, and then tinnitus became part of the conversation. So my dad started to get treatment for the tinnitus, which helped mitigate the migraines and help him understand his triggers better. This whole process took about 3 months. So if my dad had been asked the question earlier on by his civilian physician or nurses or whoever was getting him into the system, that conversation could have happened a lot earlier and the tinnitus could have been brought into the conversation. And that's just one example of the reasons why we're asking hospitals to begin to ask about military background. So next slide. So I alluded to this slide. So this is our military connected community. You might hear the acronym SMVF. This stands for Service Member Veterans and Families. So the question is to capture this whole population. Now with service members, what we're meaning by that are active duty, but especially here in Indiana, we're talking about the National Guard. We are a heavily populated Guard state. We have one of the largest Guard populations in the entire United States. And with really no active duty base outside of Crane Naval Base, this is our military force, is the National Guard. Something I would like you to keep in mind when you're thinking about the National Guard is that just because someone is currently serving in the Guard does not mean that they are a federally recognized veteran and have access to VA services. In fact, about 50% of our currently serving National Guardsmen and women are not federally recognized veterans. They haven't reached that 180 days of active duty service. And so if you were to ask these individuals, are you a veteran? They aren't. So they're going to say no, even though they are currently serving the military, wear the uniform, go to drill, and can be deployed. We also have a pretty steady reserve population in Indiana as well. Of course, we want to capture our veterans, but this includes our veterans with less than honorable discharge because they still have access to resources that their civilian counterparts would not be. And then families, so dependents, spouses, and then our caregivers who often slip through the cracks. If you're not familiar with the term caregiver, these are our individuals who are caring for our disabled veterans. Next slide. So with Ask the Question, we're not asking you to just start asking the question and to leave you high and dry. We've actually got a statewide working group that will guide any organizations through our action plan. I've got a much bigger presentation that I'm more than happy to give that'll run you through in a lot of detail and step-by-step as to how to enact Ask the Question. But in a nutshell, this is what we're asking folks to do. So our very first thing is to train. So we can give you access to military culture training through partners, some of which will offer you CEUs completely free of charge. On top of the military culture training, we're also asking organizations to take part in suicide prevention training. May not be as applicable to you guys because I imagine that's something they have access to, but we do have that available as well. After you have your folks trained on military culture and suicide prevention, then we would ask you to start asking the question. If it's a concern of where it would fit, we can definitely work with you. We have several partners that have already started enacting some best practices that we can turn to. So yeah, the next step is tracking. So one of the cool things that we can offer as a working group is a QR code that individuals who say yes would be able to scan. This QR code would be specialized to your location. So if you're a larger hospital with multiple locations across the state, the QR code can be designated for each of those specific locations. This is housed by the Indiana Department of Veteran Affairs, and they can provide that aggregate data to you. So you would be able to know those who had said yes, and where they scanned in at, and know what resources are most commonly asked for in your area. This QR code is going to connect those who scan it with their county veteran service officer and their soldier family readiness specialist, who's going to be their contact within the National Guard. And then last, we want to follow up with you. These are meetings that we would take place with our working group and your organization to make sure you're having everything that you need, and we don't leave you high and dry. So I believe that is my last slide. So I'm going to hand this back over to Dr. DeYoung to talk to you about how you can take this information you learned from Ask the Question and take it and connect folks to care. And there's my contact information, but I'll put it in the chat too.
I need to unmute myself. Thank you, LaWanda. So the second priority area that really LaWanda and I work on with organizations throughout the state of Indiana when we're trying to reduce the risk of suicide for those who serve is around improving care transitions and how this connects to the Compact Act. So the critical time for increased risk is 30 days post-discharge. The research supports that, those 30 days after a person leaves an inpatient setting is really a very critical time to make sure that we are surrounding those individuals with the care they need, the warm handoffs, the follow-up care, so that they don't fall through the crack. And many veterans are receiving their emergent care in acute suicidal crisis from each of you in your community hospitals. So as Craig mentioned earlier, when the suicide prevention team has been alerted of a veteran that's being treated at your hospital, there's really a strong need to build that communication between facilities in order to do post-discharge planning, whether it be, in the community or back at our facility or still within some aspect of your own provider's setting. So it's real important. I know you all know this, warm handoffs between the VA, community providers, the community hospitals, just that whole idea of being able to make sure that they don't ever encounter a wrong door. I remember when I was working at the Memphis VA, I had a veteran that called and wanted somebody in audiology, and I was in mental health. Now, you know, I guess there are some folks that might just say, I'm sorry, you've got the wrong number, but that's not an example of a warm handoff and making sure that they get that connection to care. So, you know, asking him, well, who's your audiologist? May I go into your medical record? May I help get you to the care that you need so that you're not left wondering who to contact or who's going to call you back? It just goes without saying, we want you to know how to reach us, and we hope that we can reach, you know, your staff too, so that we can do that critical discharge planning. And your expertise, I mean, you are experts in this community care venture and providing treatment to the veterans who present at your hospitals. You are a key stakeholder in these coalitions. And you know, to be honest with you, I need you in my coalitions. I need to have your voices and your insights and your expertise around the table as we make plans within a community to improve care transitions for those that have been experiencing an acute suicidal crisis. Next slide. So improving care transitions, that really ties back into the Compact Act and why it's so critical that we share this information, that we don't operate in silos, that we build stronger partnerships, and by meeting people, by getting contact information, by asking questions in a safe environment and knowing that you will get answers to your questions. The other part of that priority area is building connectedness. The research shows that for over 60% of the veterans across the nation who die by suicide, over 60% are not connected to care. And so it's critical that helping them find a sense of connectedness in their communities with providers, knowing what resources are there, taking an upstream approach, getting them the care they need, you know, when they need it, and giving them information on what's out there before they meet that, they're experiencing that suicidal crisis is so critical. And so this sharing of information on the array of resources, and I will tell you, with the 4 or 5 hospitals that I've done individual trainings with, it has been so powerful I mean, they are hearing about our programs. They're like, well, do you have anything on substance abuse? And do you have anything on caregiver support? Or do you have anything on medical foster homes? How can you help us support the people who come to our hospitals? And in turn, them sharing some of the array of treatment options that are available within their facilities. So it's just key to start the conversation and to make sure that we're talking and sharing information. So it's with that, I would like to, next slide, I'd like to introduce caregiver support. This is Ms. back that up, Lawanda. Okay, I'm sorry. There we go, caregiver support and medical foster home services. So next slide. I'd like to introduce Ms. Stephanie Duran, the Program Manager of Caregiver Support. Stephanie?
Hi, thank you, Dr. Lori. So I am the Program Manager for the Caregiver Support Program at the Indianapolis VA Medical Center. We cover all of the all the Indianapolis catchment area, and we provide support to the caregivers of our veterans. So our mission statement is to promote the health and well-being of family caregivers who care for our nation's veterans through education, resources, support, and services. So within our program, there's 2 segments. There's the program of general caregiver support services, which is open to all caregivers of any veteran enrolled in our system. There's no eligibility criteria. And then we also have the program of comprehensive assistance for family caregivers, which that one does have a little bit, has some eligibility criteria, which I'll go over in the next slide, please. So within the program of general caregiver support services, as I mentioned, we serve caregivers of any veteran who is enrolled in the VA. We provide training and education, supportive services, access to our 24/7 caregiver support line, peer support mentoring, diagnosis-specific programming, support groups, both in person and virtually, as well as providing assistance with navigating the VA and various referrals. Then the program of comprehensive assistance for family caregivers offers all of those things that the program of general caregiver support offers, as well as a monthly stipend for our caregivers. So to qualify, the veteran has to have a service-connected disability rating of at least 70% or more. They need in-person personal care services for a minimum of 6 continuous months based on either an inability to perform an ADL each time or a need for supervision, protection, or instruction, which means a functional impairment that directly impacts their ability to maintain their personal safety. So both those programs, you can find additional information on our national website at www.caregiver.va.gov, or you can reach out to me specifically. I have put my information in the chat. Every VA medical center does have a caregiver support program. So if you'd like to be connected to another center's program, you can also reach out to me and I can help you with that.
Thank you so much, Stephanie. Next slide. I would now like to introduce everybody to Michelle Brown, who is the Medical Foster Home Senior Services Coordinator for the Indianapolis VA.
Good afternoon. I'll speak briefly about my medical foster home program. And if you have not heard of it, I love it. It is an alternative to a nursing home, and it's provided in a personal home at half the cost. So it does merge that adult foster care with VA home-based primary care. Medical foster home accepts dependent veterans into their own personal homes and provides that 24/7 supervision and personal assistance to the veteran. Meets increasing demands for the long-term care through non-institutional care settings. As we know, as the next decades progress, our geriatric population will continue to increase. I believe we're looking at currently about 200 million veterans qualify for contracted nursing home. And in, I believe, 10 years, about 4 million could qualify for VA to pay for contract nursing homes. So the hope is we can grow the medical foster home program around Indiana and nationally, that this will provide another alternative. It really does improve that quality of life for veterans. There's typically 3 veterans and under that would be in a medical foster home. And when a veteran is admitted into a medical foster home, they provide that home-based primary care, like I spoke, but really overall care, they become more of the family in the home. They stay connected in that way. It's a safe and therapeutic environment. So currently there's around 500 medical foster homes serving about 760 veterans, but there's an expansion that's happening around the country in the next 3 to 4 years. So not every state has medical foster home coordinators, and the goal is for every state to have this program. If you have any questions about medical foster home, have any thoughts on somebody that may be interested in being a caregiver for one of the medical foster homes, or have veterans that you may be working with that may be interested, I have provided my email and my office and cell phone information below.
Thank you very much. I appreciate that, Ms. Brown. LaWanda, next slide. So that concludes our presentation today. We sincerely thank you all for giving us this opportunity to share some information about this incredibly important Compact Act, and just to highlight some of the other programs we've got at our facility, and to give you some faces and names that you can reach out to at any time for questions. So I want to thank again Lori and Casey and Madeline and all of you for spending time with us today from the Indianapolis VA Medical Center.
Thank you very much for sharing your knowledge. And reminder, recording, materials, presentation slides will all be sent to you. So that will be accessible. Thank you very much for participating. Thank you very much for presenting, and have a great day, everybody.
Thank you, everybody.